first speaker is Dr. Jeffrey Gold, professor in the Department of Anesthesiology, Pediatrics, and Psychiatric and Behavioral Science, Keck School of Medicine, University of... You already introduced yourself.
No, it's fine.
Okay, so his title will be Sedation Sparing in Routine Pediatric Medical Procedures.
Thank you very much. All right, can you all hear me? I think I'm, okay, cool. All right. Thank you all for being here this morning. It's been a great conference so far. Are we good now? How are you doing? We cool? Okay, we're cool. All right. I've been in the VR pediatric space for about 20 years now, and so my angle has always been pediatrics. So how many of you actually work in pediatrics? Okay, that's great. So this should be very applicable to y'all, and hopefully you can share the news with all your friends and colleagues. I'm right down the street here at Children's Hospital Los Angeles and at University of Southern California, and I've been in the space, as I mentioned, for a long time. So we've had a chance to see some of the trajectory of VR, AR, and now XR, and you've had some great, brilliant speakers on the main stage, and hopefully we'll be leaving you all with some great bits of information today and have a chance also to ask some questions. So you can't do this on your own. NIH only goes so far, and as we all recognize, reimbursement's not happening at any great level to actually afford us the use of XR. So you have to go philanthropic, foundations, NIH, your friends, your family, your supporters to get this work out there. I'm a scientist and a clinician, so I lean with science. You're going to see a lot of science today because I'm working towards establishing the efficacy of VR, AR, or not, right? That's really the point. We're trying to understand it scientifically. It's not just, oh, this is a cool technology and kids dig it. Like, we're actually trying to figure out, does it work? We've seen various uses of VR over our history, from entertainment to military, et cetera. Many of you probably know this, but I like to give this high overview. The evolution of VR, you can see dating back into the 60s, maybe even the 50s. My first headset that I purchased for my first VR study was $50,000. Okay? One company was making it. I had one virtual environment to choose from, which is not really a choice, right? One. And so the evolution's significant now. You can get it right off the shelf for a couple $100. I mean, it's pretty impressive. But remember, that's just the hardware. That doesn't speak to the dose or the medication that is inside of the hardware. You can see the headsets that have evolved over the years. Everybody talks about Google Cardboard. We have the Apple Vision Pro up here. So it's been some really cool sort of innovation and makes it really easy to use. In 2019, Children's Hospital Association across the whole country talked about, hey, what are the cool innovations in hospitals and pediatrics? And VR, AR, was one of those that were recognized just in 2019. So at least we're going in the right direction. We know that for a fact. Now this is a picture of Hunter Hoffman's work where he does wound care, burn care, and that's really where we started in Snow World with Hunter Hoffman and Dave Patterson at UW. And now we're moving into what I call sedation sparing or unsedated procedures. Why is this cool down here? Why? Nobody wants to speak. Okay. Anybody have their coffee this morning? Yes. Go.
Well, essentially you're saving money on the medication, but also sparing like the side effects of
Right.
medication.
Right. So if you're going in for a procedure tomorrow, NPO at midnight, right? Nothing in the morning. You're all suffering and starving, right? And then you have GA, general anesthesia. You go under. You wake up after your procedure. You're nauseous. You're dizzy. You're puking. Like, it's really unpleasant, right? That's all eliminated with unsedated procedures using VR, right? And that's not just an idea. Like, we're demonstrating that and collecting data on that. That's really cool. Kids get back to school. Parents get back to work. You know, you flip beds like you flip tables a lot quicker. Kids are out, right, versus in. And that's a really great thing. And you are correct. You save money, side effects. And if you work with the population that I work with at Children's LA that's chronically ill with complex chronic illness, they're coming in and having procedures frequently. So they're getting exposed to the neurotoxic aspects of anesthesia routinely. Okay? Not once a year, once every 10 years. We're talking 6, 12, 15 times a year. Okay? That's significant. So where have we gone? We've done for acute procedural pain. That's what I've done my whole career. People ask me, why do I keep doing that? It's important. We use it for preparation. How do you prepare a kid for a procedure? You educate them through VR or AR for chronic pain management, for mental health and wellness, and now for sedation sparing. And that's what I get to talk about today. I always love this picture. Can't get away from it. That headset, it just cracks me up. So I love showing that. Again, that's Hoffman and Patterson's work. This is some of the literature that supports, because again, I'm an evidence-leaning based person, right? So this is some of the evidence in these spaces in pediatrics, remember, okay? For burn care, sickle cell, routine procedures, chronic pain rehabilitation for patients with chronic pain management problems. Many of the authors that have published these papers are here today speaking, so it's really a privilege to be with them. This was our first study. This was the one environment that was available. Okay, that was built in 1997 by Rebecca Allen at UCLA. This is what the headset looked like, right? Pretty funny. And it was tethered and connected to a laptop, and it took 9 of my staff to roll it around the room. It was ridiculous, right? It's compared to what it looks like now. This also should timestamp me with Lilo and Stitch in the early 2000s. And we were able to demonstrate that folks in the head-mounted display condition did better during phlebotomy than all the other conditions. Then we moved to this one a few years later using street luge for kids getting IVs placed. And we were able to demonstrate that the kids in the IV condition that had VR reported no pain difference or change from pre to post, but that kids that had no VR were having a 3 to 4 time-fold increase in pain intensity in the absence of VR. So this was, how many of you have had an IV poke? Right? They burn, they sting, they're really uncomfortable. They don't always hit the first time. Sometimes they got to re-thread you a couple of times, right? Pretty annoying. So this was a very powerful finding. These are some of the headsets and what things have looked like over the years in cast removal, transnasal endoscopy, et cetera, IV placement and phlebotomy. I was having a nice conversation earlier about, well, where is that change service line, right? Are we just researching? And no, in phlebotomy, kids can ask for a VR headset. So during their blood draw. In transnasal endoscopy here with Dr. Barjois, like this has changed their clinical practice forever. If a kid wants to be sedated, they can. If the parents want them to be sedated, they can. But kids can use VR and it's done, okay? This is even before the papers come out. It's like, you know, when you get an NIH study, they have stopping rules, like when things are going too well, stop the study because it's too good. Let's just get the drug out there. It's like, that's what happened here. It was going so well. Okay, imagine the scenario that you have a child who's going to get scoped and they're squirming and uncomfortable or they're crying or they're sedated. We already talked about that. As opposed to in an environment where they're able to game or be entertained and maybe giggle and laugh a little bit and be kind of excited while they're threading the scope up the nasal passage and down into the, right? And they're calm. That means that the doctors are calm. That means the parent caregiver is calm. And that means the child is calm and will be getting out of that room very soon, right? This is a win. I call it the triangulation of data. We just published a paper recently in JMIR that talks about the caregiver's experience, the healthcare provider's experience, the child's experience. That triangulation of data is very valuable. It gives us a lot of information about the experience. In case you don't remember, how many of you love to get your blood drawn? Just raise your hand, show me who's excited, right? Nobody. Right? It's still really unpleasant, right? So this is where we changed clinical service line. You can see this kid down here. We're using butterfly needles, really tiny needles, right? But they're still very painful and sting. Look at it. You think he looks happy? These aren't cherry picked, by the way. I mean, every video is like this of kids going through this procedure. Okay? All right, so now we introduce Bear Blast, which is a game that was developed by Applied VR folks. How many of you seen this? Anybody seen this game? Okay, a couple of you, good. And now this is what it looks like.
No, it's not that guy. Did you feel that one? Huh? Did you feel it? No. I was just too busy.
It's not uncommon for a kid to say, have you started yet? We're already done, right? Imagine that. I mean, I've been inside of phlebotomy labs where kids are running around screaming and crying and they don't want to get their blood drawn and they run out. So we've published in Journal of Pediatric Psych on some of this data. I only show it to you to demonstrate that there's evidence around this space. We recently published in JAMA looking at IV placements in radiology, on the floors, and also in the infusion center. So again, trying to grow out and show the value and the purpose and operation of this. Ongoing projects, because of the negative impacts of sedation, so getting into the sedation sparing aspect of things, there's a lot of good data out there that supports the idea that exposure to these neurotoxic aspects of the medications can cause cognitive impairments, right? We don't want that to happen. We're worried about that. So we're starting to target that. This is what it looks like. There's been published papers already out there around transnasal endoscopy. My colleague Joel Friedlander out of Colorado has recently developed and had an FDA cleared scope for TNE that has a companion VR component. It's not a Pico or anything. It's kind of more like a Google Cardboard kind of thing, but it has FDA clearance as a combination partner for doing TNEs, which is really lovely. Oh, it's right here. This is it here, Evo Endo. It's a system, again, I don't work for them or anything. It's just showing you what's been FDA cleared. It's kind of nice. We have a few products in our pediatric bucket that have received FDA clearance. In the ambulatory surgical center, how many of you have been have had mask induction or witnessed somebody going through mask induction? They think they're going to die, the parents panicking, you're going to go to sleep, and et cetera. A lot of anxiety around that. So we started doing a serial intervention where we used VR for IV placement and then AR for mask induction. So this is what it looks like. This is kind of normal. A little bit of a newer headset. And again, this is just nothing's going to seem very remarkable to you here. But this is in a very loud room. The kid's gaming in his headset and getting his IV placed prior to surgery. This is the AR game we used.
Miny, Mo.
So check this out. This is really interesting.
How are you feeling?
So they measure how you're feeling at that point in that moment, and then the cognitive demand changes, right? So if you're still feeling anxious or pain or you're worried or concerned and you give a high score, then the game speeds up a little bit. So it starts to work on your cognitive load and your cognitive demand. So it's a little personalized, a little pre-AI. It's not AI, but a little pre-AI. It's customizing it to that kid's experience. This is what it looks like. Now, Apple just bought that Mira, right? Mira was developed by some USC students, and before Apple came to market, they bought Mira out because I think that was pretty much the only competition they had in the AR space that was meaningful. And so this is what it looks like coming into the OR space. And again, normally kids are distressed and worried, and which makes healthcare providers distressed and worried. So now we have a calmer, more relaxed child who's coming in. You can see and hear the nurses laughing and giggling. I think it's hysterical that this kid's like playing in this headset while they're being rolled into the operating theater. And then they either do, they'll do, mask induction, and then the child will just sort of drop the remote, we'll come in and grab the equipment, and we leave. And that's it. Now, what's cool about this, who's heard of emergence delirium? Okay? It's bad. Right? Emergence delirium is bad. If a kid wakes up agitated, angry, frustrated, they'll rip their lines out. So the theory is that if a child goes down calm, they'll wake up calm. And if a child goes down agitated, irritable, worried, anxious, etc., they're going to wake up similarly, right? So this tackles that. It's kind of cool. This tackles emergence delirium if you believe in that paradigm. So that's another reason why we're pushing it. Feedback, I won't read these, you can read them on your own, but it's very positive. Caregivers love it, and the healthcare providers love it, and kids are happy. There's been some additional, I've showed this not to toot my horn, but to basically show we're getting traction out there, right? It's not, I've been doing this for 20 years, so I lived in this little isolate of lunacy where people thought I was crazy with all this VR stuff, right? I'd submit NIH grants and they'd laugh at me, and I'd talk about this at faculty meetings and they'd laugh at me, and it was like, really, nobody understood it. And as much as I tried, they didn't understand it. But it's lovely now. I mean, I had like Jane Brody from the New York Times interview me about VR. I mean, she's like the queen of healthcare in the news journals, right? So that was a really privilege and excitement for me. So it's great to see that it's happening. We're getting coverage in Germany and across the country and other states. So it's a very exciting time. I showed you what that looks like. We're also partnering with Ready Teddy, which is a preparation, right, for kids. Kids often get sedated before they slide into the magnet because they need to be still. Because if they twitch, then there's artifact, and they got to do it all over again. So Ready Teddy is a company that built this environment that teaches kids for about 10 minutes how to be still and reinforces and rewards them for being still inside the magnet in this virtual environment that looks like this. And so we just finished a clinical trial with the company to look at the efficacy of that. It also does something really cool. It measures head movement during the VR experience and eye tracking and other metrics that are really valuable for understanding, is this kid green lit to do the MRI without sedation? Or maybe, or hell no, right? Give the kids a Versed, put them asleep, stick them in the magnet, right? So that's what this is testing, right? Green, red, yellow. And we can measure that not just because of what we see or what the kids say, but through actual physiological and gross motor movement. I just put some data up here for Ready Teddy, for transnasal, and then anal rectal mammometry, which is it's not a sedated procedure, but it's very uncomfortable for kids to go through measurement of sort of a sphincter muscle contraction and whatnot. So we're just starting to collect data on this, and we're seeing some really powerful findings for pre-post on measures of anxiety for T&E and for ARM. Not really a lot of anxiety happening during the Ready Teddy condition. Around pain, again in the T&E, is showing a decrease in pain with regards to the VR during that procedure from pre to peri. Peri is during the procedure. We have to do that retrospective account of during it. And then also caregivers reports 8 out of 10 of them feeling like the VR is being helpful for these procedures. All right, I'm going to wrap up in just a couple of minutes here, I think. Some of you may have seen this, but it's important for this business that we're all in. Whether you're a scientist, a clinician, or you're trying to commercialize a product, we're seeing increase in funds for digital health funding over the years. That's kind of lovely. And this is only in 2020, so it's 4 years old, but you can see that trend, which is why maybe some people are here, because we're seeing this trend. Openness to digital therapeutic coverage by health plans. This is really significant. How many people think that healthcare providers like the big blues are ever going to cover VR? Okay, there are 3 really hopeful people in this room. I thought I was an eternal optimist, but hey, okay, I hope so. I'm a hope junkie. I really do hope. You know, there's something I haven't said, and I think it's important. There's something called ACEs, Adverse Childhood Experiences. And Kaiser did that big study in adults that showed if you had 4 ACEs or more, you had a 4-fold increase of cardiovascular disease, diabetes, obesity, et cetera. Okay, what we do is an ACE. The way we injure children by treating children is an ACE. So we have to work harder to protect the kids from being injured during their medical care, right? So that's what it's all about. So I think that when you kind of have that paradigm around it, it makes you understand, why is this so important? Why do we care so much about their satisfaction and their comfort and et cetera? These are some ongoing studies, and I apologize because Dr. Melissa Bent is here from CHLA also, and we're doing a VR study as well. We're doing a VR study together at Children's as part of her scholarship, and so I didn't put her here, so I apologize. My apologies. I'm also working in the emergency department with a fellow to develop an intervention around IVs and blood draws in the fast-paced ED. I'm also working with Joseph Miller. He just received funding for interventional radiology, which is exciting. And then also I've been working and partnering with Exploro out of Oregon Health Science University, developing a preparation smartphone application for kids going in for surgery to prepare them for that. So again, this digital space is also about preparedness. Just to quickly show, there's other companies out there doing cool stuff, HypnoVR, this pediatric anesthesiologist published this on the Microsoft HoloLens, looking again at perioperative anxiety and trying to decrease that. SmileyScope, again, FDA cleared product for pediatric anxiety during procedures, and they've done a lot of studies in MRI and in phlebotomy and et cetera, and have had good results. So again, just wanted to show you that. And then just the things to think about for the future, all right? Lean scientifically, we have to do that, otherwise it's not meaningful. reimbursement versus cost savings. We save money on medicines, lengths of stays. There was a presenter here yesterday who demonstrated that. I love this part. I'm waiting for this to happen. Okay? I'm waiting for this to happen. How do we get physiological data to talk to our equipment to change the environment or to be like a biofeedback kind of loop, right? That's intrinsically or extrinsically rewarded. Like, let's go next level. Okay, this is a challenge to everybody in the room. Let's go next level. Let's get away from just the headset and the environment. Let's get that looped in with our physiology, right? Our neurofeedback, our biofeedback. And then multiplayer for kids, how do we get the families involved? Kind of an interesting concept. This is a group I work with, Innovate Pain, which is an international group that's studying VR, AR. And with that, I believe I am finished. So thank you so much for your time and your attention.
Questions? Yeah. Question? Any questions?
One question.
Okay.
What's the youngest age that or when do you start this at what age?
Yeah. So that's a complicated question, like what age? Because sometimes it's just headset related, right? So the Stanford group has done it with really young children using projective screens around them, but not headsets. Sometimes the headsets aren't small enough. For my studies, I go down to about 7 or 8, because I want them to be able to fill out surveys in a way that makes sense, right? So I get their subjective report. You could go younger and just ask the parents, but I want to hear it from their mouths, so I'm always in that 7 or 8-year-old space. Okay?
Another question? Yeah, back.
Do you use any kind of standardized forms to evaluate required to use VR?
Yeah, so do we use like baseline data? Absolutely. We use a variety of mood measures, sleep measures, pain measures, behavioral indices. We do that all the time. I just had this paper that's coming out in JMIR that's basically a profile of like who's a good responder to VR, right? Getting down that pathway of like who does best, right? And so I'll just leave that as a cliffhanger. You're going to have to read the article because I ran out of time. No, but yes, it's a great question. We do pre-post measures, but we also get a profile of that person who's participating in the activity.
Okay.
Ooh, that's a trick question, because you said minorities. I'm like, yeah, our whole entire population is like super ethnically diverse at Children's Hospital. We do English and Spanish, because the tools are, as that gentleman asked, the tools are available in Spanish. They're standardized in Spanish. They're not standardized in all languages. So we at least have Spanish speakers, and often it's just the parent who's the monolingual Spanish speaker, not the kid. The kid tends to be bilingual, but those are the two languages linguistically that we do. I don't want to be rude because there's other presenters, but maybe at the end. Yes?
Yeah.
Yes.
Okay.
So thank you.
Thank you
very much.
very much. Jess, thank you so much.